Good morning. This morning I've been tasked with talking about trauma, orthopaedic trauma in pregnant patients. This is Kim Kardashian, for those of you who've been living under a rock for a while, heavily pregnant. So this is based on the JOS article published in May of this year, Treatment of Pregnant Patients with Orthopaedic Trauma by this group, I think out of New York. There's also, I've taken some information from this systematic review, which was quite good, published in the American Journal of Obstetrics and Gynecology from 2013, and this Canadian guideline for management of pregnant trauma patients, and this has come from the Canadian Society of Obstetrics and Gynecology. So, trauma in pregnancy is a leading cause of non-obstetric maternal death and affects up to 8% of pregnant women. Almost 0.5% of these pregnant women will need admission, and a quarter of these admitted patients, up to a quarter of these patients, will die. In addition, there's a significant fetal mortality burden, with patients in the third trimester suffering grade 3 open fractures, having up to 65% fetal mortality rate. The most common mechanism for injury is a motor vehicle collision, and amazingly, the US collision report data suggests that up to 64% of pregnant mothers are unrestrained at the time of accident. So whether that's due to discomfort because of their pregnancy or lack of insight or fear of harming the fetus, they don't really have an answer. The consequences, of course, can be devastating. They can range from no injury in a simple fall from a standing height to catastrophic consequences such as these listed here. Placental abruption, preterm labour, death, of course. Even with small trauma during pregnancy, there are some links with lower IQ scores, developmental delays, and potentially cerebral palsy as well. So the principles of dealing with a pregnant trauma patient are pretty simple, as far as I could tell. Treat the mother before the fetus. Often the best treatment for the fetus is to resuscitate the mother anyway. Do what's necessary in the sense that, again, doing what's necessary for the mother, including radiological investigations, operative procedures, etc., and take a multidisciplinary approach. Get obstetrics involved early from the emergency department, surgical teams, trauma teams, etc. So just to briefly recap from medical school, some of the changes that occur in pregnancy. So maternal physiology, you can see there's a lot of things listed there, and I'll just go through some of the pertinent ones related to our sort of practice in trauma. There's a dilutional anemia of pregnancy that occurs when the blood volume expands at 10 weeks. This can get up to 150% of pre-pregnancy levels. The plasma volume expands before the red blood cell volume, and as such, patients can have a dilutional anemia, which can lead to poorer oxygen delivery, especially in the face of blood loss. And patients may decompensate late because they've got an expanded plasma volume, but they're not delivering oxygen to their tissues. In blood loss, prior to the mother decompensating, often blood is redirected away from the uterus and the placenta, and as such, there can be signs of fetal distress well before the mother appears unwell. There's an increase in circulating leukocytes, which means some of our labs will be unreliable. And for example, this may make diagnosing conditions such as septic arthritis quite challenging. And because of the expansion in plasma volume, there's a lot more fibrinogen circulating around, which can greatly increase the thrombotic risk, and I'll go through that a little bit later. Osteoporosis of pregnancy is a known phenomenon that occurs in the second and third trimesters. And because of the fetal requirement for calcium, up to an extra 150 milligrams per kilogram per day, over and above what the mother already requires, this is liberated from the skeleton and can lead to decreased bone density, which can lead to hip fractures, spinal fractures. Often this transient osteoporosis recovers up to 6 months post-operatively. So how should we approach pregnant patients when they present with trauma in the emergency department? Well, we should just follow the trauma principles. In the ATLS course I did, which was this one, it's chapter 12 in the book, Cover Pregnancy. But essentially we should just do the ABCDEs and deal with these patients in a regular fashion and early get obstetrics involved. And again, just reminding people that often the best treatment for the fetus is resuscitation of the mother. There are some pregnancy-specific interventions that you can do in the emergency department when a patient comes in with trauma. For example, if someone is on spinal precautions and they're over 20 weeks pregnant, they should be nursed on a spinal board with an incline, as seen here to the left, to try and move the gravid uterus off the inferior vena cava and prevent maternal hypotension. All women of childbearing age should have a serum beta-HCG, and even if patients are known to be pregnant, especially in the early stages, that can help with gestational age. This Kleihauer-Vetke test is something that's used to diagnose hemolytic disease of the newborn or maternal fetal hemolytic anemia. In rhesus-negative mothers who have a rhesus-positive fetus, only 1 ml of blood needs to mix for there to be a hemolytic reaction. And so some of the American College of Gynecologists actually recommends that all patients who are rhesus-negative should be given prophylactically some rhesus immunoglobulin. Fetal monitoring should start early, especially when the fetus is viable, so more than 24 weeks of gestation. And this should start in the emergency department, looking at heart rate and uterine activity. As I said before, the first sign of maternal distress can be fetal distress, and the fetal heart rate that we ideally look for is 120 to 160. And for patients with simple trauma, the fetus should be monitored for at least 4 hours. But if there's any concerning features, such as a low serum fibrinogen, with a risk of disseminated intravascular coagulation, PV bleeding, abdominal pain, or any pelvic fractures, then the patients and the fetus should be monitored for probably at least 24 hours. How should we approach our imaging in pregnancy? Often people get a bit touchy imaging a pregnant patient. This is not a pregnant patient, this is a dog or something. And people often, I remember when I was working in the ED as an intern, when pregnant patients would come in, people would be terrified of doing x-rays, even simple hand x-ray or something on pregnant ladies, and we probably don't need to be that crazy about it, but it is something to be cognizant of. So all the different guidelines from both the obstetrics side of things as well as the radiology boards would say that the best test to do is the safest and most appropriate test to provide accurate diagnosis and treatment, and the benefit of doing that outweighs the risk of radiation to the fetus. And this is the magic number for radiation dose in pregnancy for a fetal dose, 50 milligrays or 5 rads. These are some investigations we would commonly use, and this is the radiation dose. A pregnant lady would need 71,429 two-view chest x-rays to exceed her recommended fetal dose. So it's quite a low dose, and people maybe don't need to be so crazy about plain films. However, if you look down the bottom here, a CT abdomen and a CT lumbar spine, just 2 of those scans could exceed the recommended fetal dose for pregnancy. And so you can imagine if that's the case, a CT pan scan or one trauma pan scan may exceed the 50 milligray dose. So it's something we need to be conscious of when patients come in.
Is that a specific trimester aging?
Throughout the whole pregnancy.
Okay.
Yeah, so 50 milligrams throughout the whole pregnancy. Radiation-induced damage to a fetus can come in 3 forms: teratogenic, carcinogenic, and mutagenic. And there's a great JOS review from 2015 which goes through radiation in pregnancy. I think the author's Matson, something like that. The teratogenic effects are the ones that we know the most about, and they're fetal malformations, and predominantly this occurs during weeks 3 to 15 and is due to CNS malformations. And so you can see in this table here that they list some teratogenic effects. Between weeks 5 and 17, anything over 100 milligrays or 10 rads, there's known, and almost you would expect to have developmental delays or some central nervous system problems. Microcephaly is the other one that can occur. You can lose the pregnancy if you have too much radiation early on in the piece, so in the first 4 weeks. Carcinogenic effects are less well known, but there is a tenuous link between in utero radiation of 3 to 5 rads and development of neonatal or malignancy in childhood. And mutagenic effects are theoretical risks where there's germline gene alterations. And these we don't really know too much about. Just to give you an idea of the scope of the problem, there is a paper which was published from the Royal Melbourne in 2015 in the Journal of Trauma, which was a 12-monthly audit of all the obstetric trauma that came through in that year. And they found that 19% of pregnant patients who were admitted to the Royal Melbourne ED with a trauma call received appropriate imaging according to the trauma guidelines. And what was more astonishing finding, I thought, from this paper is that there were up to 40% of patients who had trauma calls to the Royal Melbourne who didn't get any imaging at all during their primary assessment in the ED, not even a chest x-ray or a pelvic x-ray or anything. So people are really scared of x-raying pregnant patients, but the various boards would recommend that we counsel the patient, partner and the family about the risks of radiation, use plain films in the first instance. If you're concerned about intraperitoneal fluid or intraperitoneal organ damage, then perhaps a fast scan might be more appropriate than a trauma pan scan. Shield the uterus wherever possible, and that's particularly important for us when we're taking these patients to theatre. And consider an ultrasound or an MRI where possible. One nifty recommendation I thought, which was good, the paper recommended, was that a pregnant lady can have a Geiger counter given to her when she comes into the emergency department, and kept with her throughout the admission, and this can count the cumulative dose, and that can be documented somewhere. So if there's repeat admissions during the pregnancy or something else happens, there's a record of how much she received, or how much dose the fetus received. I don't think Western would fund that, but perhaps in some centres they may do that. In terms of prophylactic therapies, for surgical prophylaxis, we can give what we like generally, although the guidelines recommend that we would avoid gentamicin, that can be teratogenic, but certainly cefazolin and vancomycin in normal doses that we would give are perfectly fine and safe to give in pregnancy. In terms of thromboprophylaxis, is really important in pregnancy. This guideline paper from 2012 from GRIA, from haematology, stated that the VTE risk in a pregnant patient without any trauma is 5 times a non-pregnant patient. If the patient's immobilised for any reason or has a traumatic event, the odds ratio of developing a clot is 7.7. And if the patient is immobilised and is overweight and has a BMI greater than 25, the odds ratio is up to 62 times. So it's a real problem, and certainly we need to be vigilant. The recommendation would be for patients to have Clexane, and of course, as Mr. Horse says, for some in-bed calf exercises, as well as some pneumatic calf compressors. Both Clexane and unfractionated heparin are fine, and they don't cross the placenta, so they're fine to be given. However, we should probably give it to these patients throughout the whole period of immobilisation, so it may not just be while they're an inpatient. Aspirin, the new anticoagulants, and warfarin should all be avoided in pregnancy. They all can be teratogenic. So certainly Clexane would be the recommendation. In terms of surgical treatment, how can pregnancy affect our decisions about operative planning and what operations we're going to do, if any? We'll obviously delay all elective procedures, that's common sense, and consider non-operative treatment of closed fractures where possible, and other injuries like distal biceps or a tendon Achilles rupture. Mr. Shepherd's not? Yeah, no. Okay. And consider, having said all that, it may be less of a risk to the patient to have them bed-bound for 6 weeks. And so if a patient is able to mobilise, for example, with a simple ankle fracture, if we internally fix the fracture, that may be a bigger benefit to the patient to reduce the other risks of bed rest and weight bearing, etc. Pelvic and acetabular fractures are a special case and they're the number one injury for fetal mortality. In the case of pelvic fractures, the increased intra-abdominal pressure as well as inferior vena cava and pelvic venous plexus engorgement can lead to dreadful and more severe hemorrhage than otherwise expected from this sort of fracture. Of course, they're high risk for placental and uterine problems, including abruption and fetal loss. And if a patient who has a pelvic fracture has a placental abruption and is losing blood there, she may need an emergency hysterectomy to save her life. Pelvic fractures, of course, as I said, include fetal mortality, but also increase the rate of caesarean section more than any other injury, as you can imagine. Where possible, we could consider non-operative treatment for pelvic fractures in a fracture perhaps like this. Rest plus or minus traction, early mobilisation and a pelvic binder if necessary. But of course, there are some fracture types that do need to go to theatre under all circumstances. So open pelvic fractures would be one. Open book pelvic fractures with pubic symphysis diastasis more than 4 centimetres or a significant diastasis once the pelvic binder is already in place, and lack of reduction. SI joint disruption. And potentially the authors of this paper recommend that instead of internally fixing these, perhaps an external fixator might be more appropriate and can reduce the trauma and potential harm to the uterus. And they also specified that supraacetabular pins would probably be preferable to iliac pins, again because of the risk to the uterus. In addition, it allows the patient to sit up, receive nursing care, and they may even be able to deliver with this in situ. In terms of fracture fixation, the authors recommend that we give the patient the least amount of radiation without compromising fracture care, and I think we do that for all patients anyway. Intraoperative fluoroscopy can give 20 to 100 milligrays a minute of scanning, so it can be quite a high dose. That's 2 to 10 rads. So I guess we need to think about radiation dose a little bit when we're considering surgical planning. Maybe think of techniques that don't require so much screening. There was a paper from Porter in the Journal of Orthopaedic Trauma in 2008 which said that for fixation of pelvic and femoral fractures on average, we would probably screen for about 39 seconds. So you can imagine that could potentially exceed the dose of 50 milligrays or 5 rads. In terms of anaesthesia, try if possible to delay any procedure more than 12 to later than 12 weeks of gestation. That's when the major organogenesis happens. There's no, according to all guidelines, including the College of Obstetric and Gynecology and anaesthetic colleges, there's no evidence that one particular anaesthetic agent is worse or better for fetal risk. And there's a similar risk profile between GA and regional anaesthetic, although some bodies would recommend regional anaesthetic to avoid overall drug and fetal drug dosing. But the bottom line is that all anaesthesia increases the risk of fetal hypoxia and fetal distress and preterm labour. So it's certainly something to be mindful of. All patients need intraoperative fetal monitoring, but especially if they're greater than 24 weeks. Because after 24 weeks, that'll be able to be delivered and the fetus is viable. If a spinal is used, an art line has to be used to rigidly control the mean arterial pressure more than 65 and avoid hypotension. And of course, we need to pay attention to oxygenation. Pregnant ladies also have a lower esophageal sphincter tone and as well have less gastric motility. And as such, prophylaxis for aspiration is really important. So ensuring that patients are fasted, and some anaesthetists will give an antacid as well. In terms of patient positioning, we need to avoid, especially in more pregnant patients in the 3rd trimester, avoiding aortocaval compression. So if the patient's supine, you can imagine that the uterus could compress the great vessels between the lumbar vertebrae. And we really need to avoid the right lateral decubitus position, so right side down, as that is the worst for blood flow return. And if possible, if we need to do an operation supine, then the patient should have a wedge or a sandbag or something to tilt them about 15 to 20 degrees to the left to release the pressure off those vessels. And left lateral position's fine. For some patients, they would recommend prone. That's usually okay as well, as long as the stomach is well padded. They just give an example of a posterior acetabular fracture that needs fixation when you would normally do it in the right lateral decubitus position, and an option for doing that is prone. And that is safe to do. So what's the prognosis for these patients? Well, it's not really good, to be honest, with patients with major trauma. These are the indications for emergency C-section. So a low fetal heart rate, decelerations, or late decelerations. And this is why perioperative monitoring and intraoperative monitoring is so critical. There's an obstetrician who knows the patient, who knows the fetus, and can make that call if necessary. So a CTG is key for these patients. If possible, we should try and delay delivery to more than 28 weeks. That's when the baby's lungs have surfactant and they can breathe for themselves without a ventilator. Even after some pelvic fractures, normal vaginal delivery is possible, and there is a series in 2007 which was published where patients had pubic symphysis plates as well as SI joint screws and delivered with those in situ without any incidence of hardware breaking. So it is possible to do that, but obviously if there's significant displacement with pelvic fractures, including the pubic rami and the birth canal, then they may need to have a C-section. And all the studies have shown at least a 15% higher rate of C-section if there's been prior pelvic fractures, not just during the pregnancy, of course, but even in the past. The prognosis for mothers and babies who suffer major trauma, there's three large case series which sort of go through this. Ali and Schiff, these series identified the risk factors for poor prognosis in pregnant trauma. So an injury severity score greater than 16, the mother having an altered Glasgow Coma Scale score, low hemoglobin, disseminated intravascular coagulation, and long hospital stay. And if the mother needs more than 4 units in the first 24 hours, it's a really poor prognosis. In this 2002 series, actually, they identified that even though an injury severity score of 16 is a risk for maternal death, an injury severity score of greater than 4 did predict some poor fetal outcomes as well. Injury severity score of 4 is like a scratch finger, it's not much at all.
That's why they didn't get imaging at the Royal.
Exactly. Canada in 2010 did a 12-year retrospective review at their hospital. This is from Dallas, Texas, and had 1,000 women that were included in obstetric trauma, and they found that in patients who had a trauma call at this institution with an injury severity score ranging from 2 to 25, there was an 8% risk of placental abruption compared to the figures in parentheses, which are the non-pregnant or non-trauma patients, non-pregnant trauma patients, rather. They had a 31% risk of preterm birth and had an 8% perinatal mortality, which is really terrible, and 35% fetal death rate with pelvic fractures, 9% maternal death rate as well, and you can see high rates of C-section. So it's an important problem which has pretty poor outcomes, but if we follow these sort of simple principles, and there's a few little things to keep in mind, we should hopefully be able to have a happy mum and a happy baby at the end of the day. Thank you.